So I run the service at Chancellor Westminster for diabetes, and I've written all the local guidelines. I'm trying to manage it, and I'm very passionate about it. I think diabetes is very, very interesting.
So alongside your normal training, you also get involved in research as well. So almost like a portfolio.
Absolutely. I think it's really important. Whatever you do, you spend most of your time. You do something that's interesting, and whatever interests you in that time, if you develop those skills, getting there, it means that you've got more fruitful work-life balance. You want to enjoy going to work and enjoy what you do. And prediabetes is an odd term. I think it suggests something that isn't quite there yet. But it's just a state of high blood sugar. It's what will eventually lead to type 2 diabetes if it goes unchecked in adults, and there'll be a large proportion of people that will be of reproductive age that wouldn't otherwise qualify for routine testing, may have prediabetes without knowing, and it's higher amongst certain age groups, high BMIs or ethnic minority groups. And you really want to identify them early on so that you can offer treatments much earlier. And usually it's just diet changes, really key. If you can capture them beforehand, that'd be even more amazing. And we did think about whether we need to bring people back after they've had their babies and maybe to look at those levels.
Why do you think that diabetes is on the rise in pregnant women?
I think some of the demographics may have changed. Lots of people these days, have you seen use continuous glucose monitors, wearable tech, which is all the rage now. I'm sure in the future there'll be a smartwatch that measure glucose through perspiration. Yeah, I'm sure that's in the next way of developing it. But essentially, lots of people do measure their glucose, and you can see how it fluctuates when you have glucose loads.
Do some people come and they believe they shouldn't be exercising because they're pregnant?
Definitely. There's a big cultural group of individuals who do think that their family members have recommended they don't do any exercise, they should stay in bed, they shouldn't move around.
How do you challenge that cultural view?
We do recommend exercise in pregnancy. We don't normally recommend people start new big exercises.
So not suddenly decide to run a marathon.
That's a bad idea. Yeah, absolutely.
So if you put yourself in the ballot, just think again.
You postpone it for a year and just tell them you're pregnant.
Oh, right. Okay. Actually, that's really good. I was unaware of that.
So things like swimming is great, spinning, try and avoid too many impact sports where you might get injured. And your center of gravity changes when you're pregnant, your center of balance, so you do have to be a bit careful about things
in the later stages.
Particularly, and nausea and vomiting, particularly early on, so dehydration. So you do have to be a bit careful.
How would you manage a situation where someone's come in with one viewpoint and then suddenly their expectations are not being met and it's completely different to what they were expecting?
It happens a lot. I'm sure you've had similar experiences. And I think you have to really listen to the individual and understand what their needs are. You need to be able to find a compromise on that viewpoint, but then also be able to express your concerns clearly. I think often it's stepwise. You may not get that at the first opportunity, but you may be with the second, and you might need to develop that relationship before they listen to you or your best.
Communication is very important. Any top tips for women on preventing diabetes in pregnancy?
So just adopt a really healthy diet, avoid processed foods, a lot of vegetables, and pairing foods is really important. So having carbohydrates pair with protein source, whether that's lentils or green vegetables or meats. And if you're hungry, don't look to bread or rice to fill you on, because you digest it really quickly and then you're just hungry again. And you're better off having something that's protein rich or slightly fattier.
Hi everyone, and welcome to our HIOS video. And today we're joined with a very special guest. So would you like to introduce yourself?
My name's Nishel. I'm an obstetrician working at Chelsea and Westminster Hospital. Thank you very much for having me.
Well, thank you for coming. I'm Dr. Deer, one of the GPs at HIOS. So you had quite a difficult journey here today. How was that?
Transport for London. I do rely on it most days, but
it's let you down
delays in Northfields. And I was among many people who were struggling. It took a while, but we're here.
Well, thank you for making it today. So would you like to tell everyone what you do? What's your job?
So I'm an obstetrician.
What does that mean?
Someone who looks after people who are pregnant, to try and get them through a safe journey antenatally during the pregnancy, and then a safe birth, and then try and look after them after they've given birth.
Okay, excellent. So you deliver babies as well?
I deliver, I help people birth their babies. I think that's the correct terminology.
That's the correct term, okay. So thanks for coming, and tell everyone a little bit about how you became an obstetrician, and what was your journey past like?
So I was born and brought up in North London.
Okay.
And decided to do medicine. I can't remember why anymore, but at some point it was probably helping people and so
Yes,
on.
as
Everybody does.
feels, yes.
And then I did medicine training in East London. And then during my training, I spent quite a fair bit of time doing obs and gynae. I did it on the electives.
Okay.
I went to the Caribbean to do obs and gynae, I remember. And then I went to New York as well.
Okay.
And then
So you managed to get 2 electives?
2 electives, yeah. The New York one was a like a scholarship. It's funded, so I had accommodation and things paid for. Just travel I had to pay for. And then the other one was I went to the Cayman Islands to do gynecology.
So it sounds like you're passionate quite early on in your medical career, and you knew what you wanted to do.
Well, I think you have to be these days. I think you have to gear yourself up in a particular direction. Okay. And then I got my first job as a house officer was in East London doing obstetrician gynecology.
Exactly.
What was really nice was that we used to have a team structure, which I think is not common these days, where as a group of individuals you work together closely on a regular basis. And that meant that I was able to do lots of things that you wouldn't typically be able to do at that level, which kind of inspired continuing.
Oh, that's really
and so therefore I kept doing it and been doing it all these years.
Okay. So what kind of things would be involved in a general rotation, and what kind of experiences did you have, and what procedures were you involved with?
You mean when I was very early on?
Yes.
So I was able to help with surgery. And as an aspiring young doctor, doing procedures is quite enticing. It's quite exciting. And I developed this quite really good skill level, which helped me when I did my esoteric later on.
What kind of procedures?
So laparoscopy.
And for everyone,
that's a keyhole surgery.
Okay.
And then other kind of endoscopy type procedures. So using small cameras to look into areas for diagnostics, problems, which is, I think is, it requires a certain level of skill bringing a 3-dimensional viewpoint from a 2-dimensional interface.
So you're looking at a screen in 2-dimension, and then you're operating in a space.
That's 3-dimensional. I think these days now they use robotic, which has a much different interface. And actually you don't even need to scrub in anymore. You use a viewfinder and it's 3-dimensional view. So very different.
Is that something you've tried yet?
I haven't. No, I'm too far gone now. I'm in, because I went to the maternity aspect, so looking after pregnant patients.
So
that's a bit of a departure from that.
Yeah. What made you transition from the gynecology point of view to obstetrics?
Some of what you end up doing is service dependent. So the way training might be structured is that there may be an emphasis on certain endpoints, whether that's an obstetrician or gynecologist, and that's typically might be because of the how the NHS, what the demands are at that stage. So I think there's a more push towards consultant jobs in obstetrics around that time. So you ended up doing funneling training through that.
Okay.
What changed? So the way it's training structure, you do your junior training, and then you do a few core years where you learn specific skills, so that you're able to do most things, and then you switch in the last 2 years to do something a bit more specialized.
I see.
And in between, I did research at Chelsea and Westminster, and it was all maternity-based research, and it was on infection and immunity, looking at immune responses in pregnancy. And because I did so much work in pregnancy, I kind of pulled that into my last 2 years of training, and therefore I came back at the same trust to do the jobs I do now.
Okay, great. So alongside your normal training, you also got to do other things and get involved in research as well.
Yeah.
So almost like a portfolio.
Absolutely. I think it's really important. Whatever you do, you spend the majority of your time as a consultant or a GP, whatever you decide to do. And in those, it's really important that what you do for the next 30 years or 40 years or however long you do it for, you do something that's interesting, and whatever interests you in that time, if you develop those skills, getting there, it means that you've got more fruitful work-life balance. I think you want to enjoy going to work and enjoy what you do.
Yeah, good. That's very good kind of tips for people as well. Are you doing any portfolios at the moment? Any other kind of bits on the side? Or
so I do. My job allows me to do one and a bit, probably more than that, days of research.
Okay.
So I still do research projects.
All right. So is that with the Chow West as well? Or?
Yeah.
Okay, that's really good. So do you have any kind of top tips for people looking to get into the obstetrics career, or even as far back as medical school and their applications?
And I think, applications are quite challenging these days. You've got to do a series of exams. You have to be really committed and really want to do it. And I think perseverance is important. If you persevere, eventually you'll get there. So you do have to want to do it. I think some of the hurdles, what the expectations are, is not necessarily what you need to be a good doctor. I think being a good doctor is about being able to communicate well to patients, being approachable and understanding, and lots of empathy. And I think most people have those skills. Unfortunately, you have to go through these hurdles to get there. So perseverance is really important. You do need to have a good knowledge base, and you have to be interested in science and interested in medicine. If that doesn't interest you, then it'll be a really hard job to keep doing. And my advice is, when you're doing training, is try and do things that you want to do later in life. So whether that's research, whether that's specific procedural skills, or maybe that's an area of particular interest. Even if you don't do that initially in your first job, in your first year or two, there's so much possibilities to do things as a consultant or as a GP. You can always develop new skills and do new things, so to make that job the job that you really, really want to do for the next 20 years. And don't be afraid to move, change, adopt new ideas, keep learning, keep changing.
So you don't have to be fixed. You can gain more experience, and you can branch and do other things.
I think most jobs give you so much more flexibility these days than they used to. A lot of trainees now do like 80 or 90% jobs where they'll spend a day, a week, maybe doing something completely different. And things like that probably help burnout, which I think is a problem, particularly in obs and gynae.
Yeah. We have a similar thing at the moment with GP trainees. They call it ITP, but they come in and do GP, and they might go and do palliative care or innovation work as well, which is very exciting for them. Do you have any particular high points during your career, or your favorite consultations maybe? Or
I have many high points. In a lot of medicine, you always remember the bad things that happen to you, and they leave a lasting memory. But I think as clinicians, we should try and remember the positive things. Lots of positive things. I mean, I deliver babies. So lots and lots of really good outcomes. When getting a thank you card or a photo of someone you've delivered some way down the line is always nice. And so seeing them again, future, that's always really nice.
That's very nice.
Positive. I still interact with a lot of the patients that were in my research studies. So that's quite nice as well. So you're bringing something back. Public engagement is really key to good clinical work and good research.
Here's an interesting question. How old is the oldest child you've delivered?
Oh, probably in their 20s now.
Oh, right. Wow.
Yeah.
And have you met them or not really?
No. Yeah, I mean, I'm just, considering the number of years of practice, probably.
Okay. So very experienced. Any particular challenging points?
I think maternity is quite emotive and quite. You really have to be. Empathy is really important. You need to understand the viewpoint of the individual. I think what's unique about pregnancy is that a lot of the individuals that come and see you are coming, optimistic and positive. They're not coming to see you really because they're expecting to have a problem. Whereas if they come to see a GP, usually they're coming to see you because
usually it's an issue.
There's an issue. Our viewpoint is slightly different. So when things don't go quite right, it's usually it can often be unexpected.
Yes.
And so you do have to be able to manage that. And try and understand that viewpoint, which is hard. I think in medicine, you're trained to be very diagnostic, look at the problem and then try and treat it. Whereas in maternity, is slightly different.
How, in kind of a short way to describe it, but how would you manage a situation where someone's come in with one viewpoint and then suddenly their expectations are not being met and it's completely different to what they were expecting?
happens a lot. I'm sure you've had similar experiences. I think you have to really listen to the individual and understand what their needs are. You need to be able to find a compromise on that viewpoint, but then also be able to express your concerns clearly. You don't include with any misinterpretations of what might be happening. So I think often it's stepwise. You may not get that at the first opportunity, but you may be with the second, and you might need to develop that relationship before they listen to you. Yeah. Or your best advice.
Communication is very important.
Yeah. It is.
So I'd like to move on a little bit. And one of the topics we were planning to discuss today was diabetes or pre-diabetes even. And are you involved in your line of work with pre-diabetes and diabetes during pregnancy?
Yes. So I run the service at Chelsea Westminster for diabetes, and I've written all the local guidelines. I'm trying to manage it, and very passionate about it. I think diabetes is very, very interesting, on the rise. Pre-diabetes is an odd term. I think it suggests something that isn't quite there yet. But it's just a state of high blood sugar. It's what will eventually lead to type 2 diabetes if it goes unchecked. The way we diagnose it is with a blood test, which GP practices do quite often in high-risk groups.
Yeah.
But my understanding is it's on the rise, particularly in adults, and there'll be a large proportion of people that will be of reproductive age, and a lot of the demographic that wouldn't otherwise qualify for routine testing may have pre-diabetes without knowing, and it's higher amongst certain age groups, high BMIs or ethnic minority groups. So in maternity, we adopt NICE testing, which is doing a glucose tolerance test.
So what is that exactly? What does it involve?
So normally when you eat something, your blood sugar will rise and it'll come down, and our body's usually really, really good at regulating it. And if you have a lot of sugar, it will go up to a much higher level than expected. And a glucose tolerance test is just a measured load of glucose, and you're just assessing how well your body kind of removes that glucose from your bloodstream and how quickly. And ideally, you should do it within a time frame.
So do you give the lady a chocolate bar?
We give them a 75 grams of glucose. It's quite a lot of glucose in a liquid drink, and it's a liquid because it's absorbed faster.
Okay.
It's not very natural way of testing, but that's what we use. It's what's the gold standard. Lots of people these days, have you seen use continuous glucose monitors?
Yeah, we've seen
wearable tech, which is all the rage now. I'm sure in the future there'll be a smartwatch that will measure glucose through perspiration.
Yeah,
I'm sure that's in the next way of developing it. But essentially, lots of people do measure their glucose, and you can see how it fluctuates when you have glucose loads.
Yeah.
But this kind of artificial test is the way we diagnose it. But pre-diabetes isn't necessarily diagnosed by that. You usually use a HbA1c, which measures how much glucose is stuck to elements of a red blood cell. And that gives you a better indicator of whether your glucose has been high over a long period of time, which is probably a bit more usable.
Yeah, we definitely use that value. We try not to use it in pregnancy because it's not always accurate, but for other people we do. And then, we usually run a diabetes prevention group as well for patients. So, I think that's really, really important. It would be wonderful to have these groups identified before pregnancy and then offer them a prevention group, because they definitely do better. We do that blood test in pregnancy, and I'm probably going to start doing that for all women who book in at Chelsea Westminster to try and pick up those individuals. The problem is, as soon as you're pregnant, because if your blood becomes more dilute when you're pregnant, that level will probably drop off. It's not as accurate.
So it's not as accurate. And during the pandemic, lots of NHS trusts shifted to use that as a diagnostic test for diabetes, because it didn't want people coming in and
staying for long periods and being exposed to COVID.
Exactly. So they moved to that, but it wasn't very good at diagnosing diabetes, but perhaps it would be helpful for the pre-diabetic group. Those individuals have a tendency of having much higher glucose levels in pregnancy, where their glucose levels don't go down with normal food, and that high blood sugar will transfer to the baby and affect the baby's hormones and affect growth and other problems. that you encounter in pregnancy, they're ones that typically will far more likely to develop diabetes in pregnancy. So you really want to identify them early on so that you can offer some treatments much early. And usually it's just diet changes. Really, 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 really key. And I'm sure you find that in GP practice.
Yeah.
And if you can capture them beforehand, that'd be even more amazing. And we did think about whether we need to bring people back after they've had their babies and maybe to look at those levels. And I know a lot of GP practices do that.
Yes. I know there's research going on into that at the moment as well. And we're being advised to do a HbA1c after they've had their pregnancy. So why do you think that diabetes is on the rise in pregnant women?
I think some of the demographics may have changed. I think some women are getting pregnant much older in life. On the other side, I think people are also a bit more health aware as well. So I think I do see a bit more people who are much more clued up about their diet and lifestyle a bit more. But I wonder whether the demographic has changed over the last 10 years.
So do you mean that maybe there's different foods and exercise amount and lifestyle?
Yeah, more processed foods are available now than they perhaps used to be. I think it's the same reason why obesity is on the rise. It's probably a similar sort of pathology across the UK.
Are there any particular foods which are bad in pregnancy from a diabetes point of view?
We all recommend low glycemic index foods.
What does that mean?
So it just means that foods that take a long time to digest and absorb and transfer to glucose. So using things that are wholemeal, things that are seeded. We tend to want to restrict volume, so you eat a little bit less, try and avoid white bread, white rice.
Yes, so having the brown equivalent.
And we do recommend lots of exercise as well. So
yes,
pregnant women.
In pregnancy as well?
Absolutely. Good cardiovascular health is really important for long-term health, but also reduces problems like high blood pressure in pregnancy.
Do some people come and they believe they shouldn't be exercising because they're pregnant?
Definitely. There's a big cultural group of individuals who do think that their family members have recommended they don't do any exercise, they should stay in bed, they shouldn't move around.
How do you challenge that cultural view?
So very early on when we see them, as soon as they engage with us, or even if they engage in maternity units, there is this, we do recommend exercise in pregnancy. And actually a lot of materials that are available on the NHS do talk about moderate exercise in pregnancy. We don't normally recommend people start new big exercises.
So not suddenly decide to run a marathon.
That's a bad idea. Yeah, absolutely.
So if you've signed up if you put yourself in the ballot, just think again.
You postpone it for a year and just tell them you're pregnant.
Oh, right. Okay. Actually, that's a good ride. I was unaware of that.
So things like swimming is great, spinning. We try and avoid too many impact sports where you might get injured. And your center of gravity changes when you're pregnant, and your center of balance, so you do have to be a bit careful about things
in the later stages,
particularly, and nausea and vomiting, particularly early on, so dehydration can be quite common. So you do have to be a bit careful. But good heart health is really, 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 really something we promote.
Yes.
We definitely try and challenge the view that you shouldn't do anything.
Any top tips for women on preventing diabetes in pregnancy?
So just adopt a really healthy diet, avoid processed foods, a lot of vegetables. Pairing foods is really important. So if you're having carbohydrates, pair with a protein source, whether that's lentils or green vegetables or meats. And if you're hungry, don't look to bread or rice to fill you on, because you digest it really quickly and then you're just hungry again.
Yes.
You're better off having something that's protein rich or slightly fattier. Just takes a bit longer to digest.
What do you mean by that? Surely fattier foods are unhealthy.
I think in pregnancy in the short term, it's probably okay. Yes, your long term, if you do that for the next 10 years, your cholesterol levels will go up and it's not recommended. But in pregnancy, we're not too worried about that.
What about eggs?
Eggs are fantastic. Beautiful source of protein and fat, all of the good things. People do get sick of eggs, though. So you could pair it perhaps with some avocados or you can use cheese, things like that, or something else to try and mix up the flavor.
We also recommend mixed nuts.
Yes.
It's a good source of protein. And if you're feeling snacky as well, you can have a small handful of those.
Yeah, unsalted, unsweetened.
Unsalted, yeah, and not fried as well.
Not fried as well. You can roast them.
Yeah, yeah. Any other tips from a point of view of the change in the demographics? Maybe you might have more patients from Indian culture go in, and any tips for them from a diet?
There's lots of things available, like Diabetes UK. There's a lot of charities that do have good meal options that are cultural cuisine that's a bit more tailored.
Okay.
But actually, most Indian foods are quite heavily, lots of vegetarian foods, lots of emphasis on vegetables. I think there are options that you can adopt to minimize your carbohydrate
question. What do you think about ghee? Have you got any views on that?
I don't use it. I think my grandfather used to use it a lot. I think that's fine. It's from a pregnancy point of view in the short term. I think it's fine. If you're using it to cook with, if you're using it in your foods, I don't see any issues with that. I know clarified butter is not as healthy as normal butter, but I think in the short term it's okay.
We'll say just for the short term, and then in terms of long term, do some more reading and speak to us about it. And especially if you have high cholesterol issues, then you've got to be a bit careful about saturated fats and things.
Yeah.
Okay. Brilliant. Thank you very much for coming today. And it's been very enlightening and informative for all of us.